Hello. Will somebody introduce? Give the biodata or something?
I think briefly, yes. I can do self-introduction if you want.
Dr. Prabhakar needs no introduction. Dr. Prabhakar Sharma is a son of the soil and he is a native of Hyderabad. He graduated from Gandhi Medical College,
Yes.
later migrated to US, and he is an excellent academician and a wonderful clinician as well. You can see he is the chief of nephrology, and now presently he is in Texas Tech Health University Health Science Center as chief of nephrology. He is a professor of medicine and physiology. Now today's topic is Dr. Sharma will be speaking on cardiorenal syndrome and of course the recent cardiovascular kidney metabolic syndromes. So Dr. Sharma.
Thank you for that introduction. Good evening, my nephrology colleagues. Let me start by disclosing that I have no financial or conflicts or anything like that. And then I will always start with a, due respects to my teacher and mentor in University of Texas, where I did my initial training. And this is Donald Seldin. Most of you may not know him, but he is the founder of the American Society of Nephrology, and also he founded the discipline of nephrology. He was chair of medicine at University of Texas in Dallas from 1950s for almost 40 years, and then continued on. And this is a photo I took. I met him, and then we had these photos taken. But this was when he was 94 years old, and he died in 2018 at the age of 97. He was full-time professor at that age, while when he died at the age of 97. So he was a source of inspiration not only for me, but actually for a lot of nephrologists and even non-nephrologists, because he was the chair of medicine. And he is solely credited with obtaining 6 Nobel Prizes in the University of Texas, Dallas. So with that, I want to move on to the cardiovascular kidney metabolic syndrome. Before I do that, I want to mention in the last few years, we have seen a number of clinical trials in nephrology that had positive impact or positive results. Historically, nephrology did not have that many clinical trials in the past as compared to cardiology or oncology. The recent clinical trials have given hope to a lot of patients who have kidney disease, but sometimes in these clinical trials, some unexpected findings come up, and those findings will form the basis or will give us some new leads in pathophysiology, as well as form the basis for new therapeutic inventions. So I will start with a couple of examples. All of you know that ACE inhibitors and the ARBs were developed primarily to control hypertension, and this happened back in 80s. But soon after, during the clinical experience post marketing analysis, it became clear that patients with heart failure were benefiting significantly. So a systematic randomized clinical trial was done which showed that beyond any doubt that ACE inhibitors improved outcomes in heart failure. That was the consensus study that was published in 1990. Soon after, in 1993, ACE inhibitors were shown to be beneficial in kidney disease. And then ARBs came into existence, and ARBs also were found to be renoprotective and cardioprotective. But this protection was primarily, predominantly seen with ACE inhibitors and primarily in heart failure till the year 2000, when these agents, particularly ACE inhibitors, were shown to be effective in changing the outcomes in coronary artery disease. And that is actually the HOPE study that most of you may know, which involved about 9,000 patients. I think only 3,000 patients were diabetic in that. What that study showed is that if you take ACE inhibitors after having an MI, your chance of living is about 26% more than the others. So that's a fantastic result. And so immediately the American Heart Association and the American College of Cardiology incorporated using ACE inhibitors as a part of therapy for all patients with coronary artery disease, which is now the norm. So, but what is interesting is, when this study, the HOPE study, was analyzed further, as I said, there were 3,000 diabetic patients and 6,000 non-diabetic patients. The diabetic patients and non-diabetic patients showed this benefit in terms of cardiac protection and cardiac outcomes. But in the non-diabetic population, the development of new onset diabetes was significantly reduced. It was an unexpected finding. Then subsequently, all studies that were done using either ACE inhibitors or ARBs too in cardiovascular trials showed that the new onset diabetes is decreased. That's an unexpected finding. So based on that, people went back. This is called translational research in reverse, or like bedside to bench. So then that led to some new findings that showed the interaction between the renin-angiotensin system and the insulin. It's interesting if you think about it. You use the ACE inhibitors which act through the renin-angiotensin axis, and then you see that it protects you from diabetes. There is also some evidence that people who use these agents, the diabetic control is much better. So with all this data, actually there is a big meta-analysis that included 75,000 patients that confirmed this finding. So this kind of finding inspires many people, including me. We did a lot of work on this and came up with what is called angiotensin insulin crosstalk, that basically tells how these two signaling systems interact. So the recent clinical trials that I was alluding to earlier, in fact, not the previous ASN, but the one before that, in 2022, when these trials were just published, the ASN leadership was so excited that it almost looked like there's a new hope for all the CKD patients. Now, the new drugs and new clinical trials, what they have shown is, as you will see in the other slides, I'll get to this in a second. Drugs that are being used for diabetes turned out to be protective. The new drugs, protective for the heart and the kidney. Now, we know this cardiorenal syndromes from a long time. I don't have to elaborate on this. This is a well-established concept. The acute or chronic disorder of one organ affects acutely or chronically the other organ, and then you have various syndromes. Basically, that also inspired me to look at some of the pathophysiologic mechanisms that overlap between the kidney and the heart, and I'll show you that in a minute. But And then we also know this metabolic syndrome for decades, which is basically initiated by adiposity and leads to hyperlipidemia in the form of high triglycerides and low HDL, and also causes elevation of blood pressure and insulin resistance. And all these constituent factors in this metabolic syndrome are high-risk factors for cardiovascular disease. We know this, but note that there is no mention of kidney parameters in this metabolic syndrome. So now, the cardiovascular kidney metabolic syndrome. Why I am talking about this is a relatively new concept that American Heart Association kind of investigated in detail in terms of pathogenesis, and also developed some new guidelines for management. So if you look at this diagram, the initiating event here is also adiposity. And then one of the things is most people think of adipose tissue as a fat storage organ, but we all know now that it's, the fat tissue is biologically active and secrete active cytokines that can cause many things, including inflammation. As you can see here in the diagram, you can see oxidative stress and several other parameters, several other pathogenic mechanisms that are initiated by this. What is also important is the ectopic fat deposition. The classic example that we're all familiar with is the fat in the liver. As you know, the so-called non-alcoholic fat steatosis is not a benign thing. It can lead to cirrhosis and cancer. So what about the role of fat that is around the kidney or the heart? So that's another aspect that is becoming a subject of interest. And you can see that the pathophysiologic factors that are initiated by adipose tissue then lead to both renal and cardiac damage through various mechanisms. So now, coming up with this kind of concept and terminology, we should have some strong basis. As I said, the American Heart Association, in conjunction with the American Society of Nephrology, came up with this, not only terminology, but also the evidence behind this, and gave some new guidelines for screening and management. So this was published actually in Circulation November 2023, so it's very recent. And I would strongly encourage you, if you're interested, to go through those guidelines. But basically, this slide shows the epidemiological evidence for the existence of a cardiovascular kidney metabolic syndrome, or the CKM syndrome. So you can see that there is overlap, considerable overlap between all these major clinical syndromes. One of the reasons why we are talking about this is these disorders are typically treated by individual specialists as if they are completely different diseases. But as we can see, as you will see later on in my slides, that there is not only overlap, but there may be a common background basis for this. Insulin resistance, as you know, is the basis for a lot of things, including not only just diabetes, but cardiovascular risk. So you can see that cardiovascular disease and heart failure are 2 to 4 times more common in diabetics. 40% of diabetics develop CKD. 60% of CKD patients have diabetes. So these are all numbers that stress the importance of coexistence of these conditions. Now, one can say that these are just associations or just coexistent conditions. This was the debate many years ago about metabolic syndrome. It actually blew up into a big conflict between endocrinologists and cardiovascular specialists. But ultimately, we all now understand it's metabolic syndrome is a disease entity by itself, and it goes on right now that way. So in view of these pathophysiological connections and the therapeutic implications, the American Heart Association recently came up with this term and came up with a lot of descriptive literature. So the other important aspects are, that diabetes, as you know, is also a risk factor for heart failure. And in patients, if you check heart failure patients, like I was talking about non-diabetic patients developing diabetes, the risk of developing diabetes in heart failure patients is also high. The risk of developing diabetes in CKD patients is also high, much higher than the general population. So all these data, pieces of epidemiological facts stress the possibility that there could be common underlying pathophysiologic mechanisms. Now, one of the things, why do patients with renal failure have more incidence of new onset diabetes? Could be effect of uremic toxins. As you know, there is some degree of insulin resistance imposed by or imparted by the presence of CKD, the so-called pseudo-diabetes of uremia. Now, so because of all this, now we have come to not only accept this term, but now you will see a lot more of this characterization of this syndrome. Now, pathophysiologically, what is interesting is the same mechanisms operate in cardiovascular disease, renal disease, and so inflammatory cytokine production, especially from the adipose tissue, can lead to insulin resistance as well as renal and cardiovascular damage. There is also associated activation of the renin-angiotensin system and sympathetic nervous system by the adipose tissue. By the way, one of the causes of hypertension associated with obesity is this activation of these two systems. And then I was talking about the role of peri-organ fat. I'll mention about that in a second. Here you can see the correlation. This is well known to all of us that kidney disease is a risk factor for heart disease. Both proteinuria and elevated creatinine are much more significant, greater risk factors for cardiovascular disease than diabetes or smoking. And then as the GFR declines and albuminuria increases, both the cardiovascular and cardiovascular disease and hypertension progresses. So there is correlation between the kidney, what is happening functionally with the cardiovascular disease. Now, this is a meta-analysis of proteinuric studies where bottom line is proteinuria is associated with 50% increase in the cardiovascular disease. And again, the rate of decline of GFR also has an impact on not only cardiovascular mortality but also all-cause mortality. Now, I want to spend a minute on what I was doing in my lab. This is a ZSF rat. It's a rat that we characterized many years ago and published in JSON. Actually, what we were doing there is to try to develop an animal model for diabetic nephropathy. But it turns out GSF rat is a model for complete full-blown metabolic syndrome, develops severe hypertriglyceridemia, obesity, and what the picture there shows a normal rat and GSF rat at the same age. So you can see the GSF rat is obese and has all the manifestations of metabolic syndrome and also develops heart failure, actually dies very early with the heart failure. So it was a really good model for us to use to study what we are talking now, because the rat model develops diabetes, heart failure, hyperlipidemia, hypertension, and actually it's severe hypertriglyceridemia. So we have been using this for quite some time. But my interest in showing this slide is to show you, tell you that what I did was to look at the heart and the kidney and see in this model where they develop both failures at the, after some time, whether the pathogenic mechanisms involved are similar. And lo and behold, that's what we found, that when we did the next-gen sequencing analysis, we found similar pathways that are differentially expressed. What this means is that underlying pathophysiology in both heart failure and renal failure could be similar. And look at the therapeutic options. We'll get to that in a second. But all this is kind of exciting that the pathogenesis may be overlapping. And I talked about the perinephric fat and pericardiac fat, and this is peri or epicardiac fat. Basically, we thought for a long time this has no relevance, but there is a lot of active interest and investigation going on, and there is the thickness of the perirenal fat has an implication or correlation with the rate of decline of GFR in the case of CKD, and the same thing with the pericardiac or epicardiac fat. So these fat deposits around the organs are not benign. And then this is even more exciting. So in patients with hypertension, essential hypertension, there could be insulin resistance, and this is what they investigated and showed almost 40 years ago in the New England Journal. It was followed by an editorial, but basically this is a very interesting hypothesis that what this means is people with essential hypertension may have underlying insulin resistance, and so that leads us to kind of hypothesize that hypertension, diabetes could be one disease with a big spectrum, hypertension at one end and diabetes at the other end. Now the last piece of evidence I want to show is by drug trials and medications. Some of these new trials that I was talking to, including the GLP-1 agonists, have shown renoprotective effects. Remember, these were drugs that were developed for diabetic control, but they also turned out to be cardioprotective. These are all some meta-analysis. This particular one actually is with 3 different GLP-1 agonists. And same story with the SGLT2 inhibitors. Now you all know that SGLT2 inhibitors, which were primarily developed as an anti-diabetes drug or drugs, have renoprotective effects and also cardioprotective effects. These were all unexpected at the beginning, but now turned out to be very important. And now, we use them as a part of therapy for cardioprotection. Not even just diabetics, even in non-diabetics, these are useful. And the last group of compounds that have shown to be beneficial in similar way is aldo blockers. Now, people, all of you can remember those days when we used spironolactone. The RAIL study actually showed cardioprotective benefits, and then the eplerenone came into existence, and the EPHYSIS studies showed similar thing, and now we have finerenone, which also demonstrated cardio and renal protection. So these are some studies recently that showed both benefits in renal and cardiovascular outcomes. And then going back to the cardiovascular CKM syndrome, there are several social and ecological factors that influence the development progression. And the AHA has then, for the sake of management, staged, just like we do stage CKD, there is staging of the CKM. Stage 0 is basically normal, and stage 1 is where there is a adiposity increase like obesity. And stage 2 is where you have the risk factors like hypertension and diabetes. Stage 3 is preclinical cardiovascular disease, and stage 4 is clinical vascular disease. And screening of various components is very important in order to improve the outcomes. And including kidney parameters is of immense importance. And this is something that was neglected by the the preventive task force in US. They did not include renal parameters for a long time, but now we understand this as important. And as far as management, these are some of the guidelines mentioned by the American Heart Association. I won't go into the details because the print is kind of a very small font, and basically each individual component has to be treated, and they have given guidelines. What you will see in a summary diagram is that there is considerable overlap on how we manage these different conditions. That goes to show that the pathophysiology is very similar in these 3 different disease states. I want to actually point out in stage 4, you may not, the very last line talks about ARNI, which is angiotensin receptor blockers and neprilysin inhibitors. These are routinely used in the management of heart failure. But the impact of using these on renal outcomes was not well known, but now we're beginning to understand that, and so they have included this, ARNI as a part of the CKD management when there is concomitant CVD. And so it has been shown that in the presence of CKD, these what we call Entresto, which is the combination medication, decreases the adverse kidney events, hospital readmissions, and cardiovascular death. Now this is the perhaps the last but one slide, which shows a new paradigm in the management of diabetic kidney disease. What is new is, of course, you all know that lifestyle modification is the number one thing that you advocate for all these disorders. But in the first line therapy, now you have SGLT2 blockers. So that's kind of new. And then when additional therapy is required, you can add mineralocorticoid receptor blockers and GLP-1 agonists. So it's very fascinating how drugs that are developed for diabetes are proving to be beneficial in heart and kidney disease. And then, of course, management of underlying precursor conditions like hypertension, diabetes, hyperlipidemia is of paramount importance. Do not underestimate the impact of smoking on progression. So that's another thing that in the lifestyle that I would mention to everybody. And so this is like the summary diagram, which basically I wanted to show here that the treatment is kind of very similar for metabolic syndrome, metabolic adiposity, obesity, renal failure, and cardiovascular disease. Now, one more point I want to say is when a patient gets admitted or is seen in the emergency room with symptoms of heart failure, the first test that is done in our hospitals is pro-BNP, brain natriuretic peptide. Brain natriuretic peptide, as the name indicates, is a natriuretic substance, right? So it should cause natriuresis, and when there's a lot of it in the blood, you should expect a lot of sodium in the urine, but you don't. And so even with the normal renal function, so the BNP is not acting on the kidney. And as I imagined a long time ago, there is resistance at the level of kidney, and you all know this now, and that is the basis of this elevated BNP in these patients. It's kind of similar or analogous to type 2 diabetes, where you have a lot of insulin and but hyperglycemia at the same time. So that's why neprilysin inhibitors, which is an inhibitor of the breakdown enzyme for BNP, is used in the therapy and is effective. So I want to wrap up by saying that this whole new concept of CKM syndrome gives us a chance to understand that the pathophysiology underlying kidney disease, heart disease, and even the metabolic disorders may be similar, diabetes. So I showed you some evidence about the insulin resistance hypertension. That is very exciting to me. That it is hard to imagine hypertension and diabetes as one single disease, but that's what was shown. And then there is more recent data that is supporting that kind of hypothesis. I'm going to stop here and invite any questions.
Thank you very much, Dr. Sharma, for your very lucid and wonderful exposition about the CKM syndrome. Normally, it could have generated a lot of discussion and questionnaire, but the organizers are worried about the next program, that is the governor of Telangana coming up and taking the main program, that is the inaugural function. But I would like to invite a couple of questions because we have a little time before that. And before the audience gives any questions, I have one question for you.
Yes, sir.
So this is a very new and new terminology, cardiovascular kidney and metabolic syndrome. But do you mean to say that the earlier cardiorenal syndrome does not exist anymore?
No, that's not what I was saying.
And what about those people who do not have metabolic syndrome but still have cardiac and renal disease?
Yes. The cardiorenal syndrome is still an entity. There's a lot of interactions between the heart and kidney do exist. But this one expands that syndrome to include diabetes and other metabolic factors, including hyperlipidemia. Because hyperlipidemia, as you know, is a risk factor for heart disease, but it's also a risk factor for kidney disease. And the whole concept of CKM syndrome kind of includes, or it's an all-inclusive syndrome, which may have more therapeutic implications and may, you may see more new drugs that can address all the three entities.
Yeah, just 1 minute, Dr. Srinivas. So there is one small, but the question may look a little silly, but in the kidney transplant, we see a lot of times the surgeons removing all the fat around the kidney. Do you want us to advise them not to remove the fat, the perinephric fat, considering you said the fat removal will produce a decline in the GFR?
No. I said the thickness of perirenal